Good afternoon, everyone. This is Eliza Norcross from the American Planning Association, and we are so glad that you've joined us for the third webinar in the Planners for Health series. Thank you for taking the time out of your day to discuss how to apply a health equity lens to healthy communities work. A few housekeeping notes before we get started. If you have a question or a concern during the webinar, please let us know via the chat box. Around 4 p.m., we'll transition into a discussion with the panelists and all of the attendees. And during this time, you can share your thoughts or questions by typing something into the question box or by entering an audio pin and raising your hand. Now I'd like to introduce our colleagues at the Prevention Institute. APA has been working closely with Rachel Bennett and Sandra Vieira on designing the Planners for Health curriculum, and we're really excited to have them with us today. PI is a national nonprofit center dedicated to advancing primary prevention. Prevention Institute strives to shift the overarching health mindset and approach from one that focuses solely on treating sick individuals to one that prevents disease, violence, and injury from occurring in the first place. Their work focuses on healthy eating and active living, positive youth development, injury and violence prevention, health system transformation, and mental health and well-being, all guided by a commitment to health equity. Sandra Vieira is an associate director, and Rachel Bennett is an associate program manager. So, Rachel and Sandra, take it away.
Great, thank you so much. And again, thank you to the American Planning Association for inviting us to be part of today's webinar and the series. While our focus this month is on applying a health equity lens, and we'll highlight local efforts and partnerships that advance health equity through planning efforts, in many ways this entire series is about opportunities to support health and health equity in all communities, but especially in communities made vulnerable by structural drivers like racism, classism, genderism, heterosexism, ageism, ableism, all of the isms that many of you I know are very familiar with. So what is health equity? Let's take a look at the definition that Prevention Institute is proposing that for today's webinar we use. It's a definition that we use. It's the Braveman-Kumanika Fielding definition. Health equity means that every person, regardless of who they are, the color of their skin, their level of education, their gender or sexual identity, whether or not they have a disability, the job that they have, or the neighborhood that they live in, have an equal opportunity to achieve optimal health. So I think that really speaks well to the structural drivers that we mentioned earlier on, and that health equity really is about changing systems, policies, environments, and supporting people with health at a community level to push back against those structural drivers. So many of you are familiar with this definition and also have others and use other. And that dialogue about how each definition adds to the movement for health equity is really important. So we welcome an open discussion about the different definitions and the different concepts. We wanted to also raise that the dialogue brings up a discussion on health equity and equality relate. So we've seen versions of this image here that really tries to depict equality and equity. And as others have pointed in previous webinars in this series, that they are not the same thing. And in fact, are really kind of assuming different starting points and different outcomes. Part of what we think is important to point out in this image is that to get to equal outcomes in health and safety, whether that's lower rates of chronic diseases or increased safety in and around schools, for example, we need to have an equitable approach that involves focused resources and strategies for people and communities who are experiencing inequities and inequalities in health and safety. So another way we can think about it is that equity is part of the process It's thinking about all of those investments, all of the things that can support people and communities in being healthy. And equality is an outcome. That's when we have everyone, you know, in this image, getting and accessing that apple. So I think that's a really important piece to keep in mind, that equality and equity are not the same, but they do relate, and that we really are focused on applying an equity lens to get more equal outcomes in health and safety. So this is not new for public health, and I don't think for planning either. And I think it's a really good opportunity for us to think about and, you know, briefly revisit the sort of history that both fields have had working with other sectors and in community environments to promote health equity. For public health, for example, we've had a long but progressive road in creating systems and environments that promote health equity. It harkens back even to the evolution from a biomedical model that really focused on the individual and treating illness and injury after they've occurred to more of a community health model. And the work of Dr. Jack Geiger and Dr. John Hutch, for example, really points to how that evolution started to happen in places in the South, for example. So just a quick history recap here. In 1965, Dr. Jack Geiger and Dr. John Hutch opened one of the first 2 community health centers in the U.S. in Mississippi. The invention of the double-row cotton picking machine had recently exacerbated poverty by replacing an entire population of sharecroppers. So to assess the needs of the community, the Mississippi Health Center began holding a series of meetings in homes and churches and schools, and as a result, residents created 10 community health associations, each with its own perspective and priorities. Part of that meant that the doctors began writing prescriptions for food, not because the individuals didn't realize that that was a healthy way, you know, to approach better outcomes for their own health, but really to get grocery stores and pharmacies to stock food so that people would have access to healthy food in their neighborhoods. So health center workers recruited local Black-owned grocery stores to fill the prescriptions and reimburse the stores out of the pharmacy budget. A quote from Dr. Geiger was, "Once we had the health center going, we started stocking food in the center pharmacy and distributing food, like drugs, to the people. A variety of officials got very nervous and said, 'You can't do that.' And we said, 'Why not?' They said, 'It's a health center pharmacy and it's supposed to carry drugs for the treatment of disease.' And we said, 'The last time we looked in the book, the Physician's Desk Reference Book, which is a big book for physicians, the specific therapy for malnutrition was food.'" So really getting to the heart of health and of public health and community health. And part of their approach from there was saying, well, let's provide funding for things like tractors and machinery that would allow community to grow their own food and have access to quality, affordable food to treat some of the illnesses in that day. That has grown now even to, you know, an example we pointed out last time, which is hospitals really thinking about how they can leverage their expertise and their resources to change community conditions outside of hospital settings. So this is Cincinnati Children's Hospital really thinking about how GIS mapping could hotspot areas of high asthma rates, where then they could partner with local media and with the legal aid to ensure that landowners were providing healthy housing and resulted in a decrease of asthma rates in that community. And in more recent history, we're seeing this health equity-driven approach applied to different settings as well. We can think back, for example, not too long ago to healthy food in schools, and that really being an opportunity to support equity by ensuring that the quality of food served at school would be higher and would be able to provide better nutrition for children, particularly children in low-income families where their breakfast and lunch were kind of the majority of their daily nutrition. And for some, school food was the only reliable source of food available. So, which meant that there was a support around providing for physical health, but also influences kids' ability to concentrate and learn. So this has been a really big effort on the public health end in recent years and continues to evolve and grow. But as the research shows, it's highlighted here on the screen, it's changing behavior and having impact. So there's a lot of great work to build on moving forward.
Excuse me, pardon me, getting over a cold here. Coming from a public health approach is really, it's not new for the planning field, but I think as so many of us know, the planning field has kind of come back to its roots in recent years and taken up that public health mantle. Again, like we talked about in the data session, looking at what are the areas of interest and need in the communities we serve, what are the health conditions our communities are experiencing, where are those health conditions greatest, whether they're chronic disease rates or injury rates or violence or other problems, and then why are those conditions the way they are. That is a public health approach, and that's a health equity approach, and then targeting resources to the areas where there are the greatest needs and opportunities, really through kind of a harm reduction approach, but also building on community assets and really building from the community voice and perspective. So public health really has that long history of looking at equity and working through approaches that are sort of outside the bounds of public health itself. So through education and school environments, or through agriculture and food systems, like Sandra just talked about, and now through planning. So I think one thing that's really interesting in the Planners for Health work is we're seeing that planning and public health have this new opportunity to think together about what are the major issues right now for our communities, whether it's unemployment and the need for economic development in communities, or poor housing conditions or unaffordable housing, and the need for planning and health to make that case that we all need access to safe and healthy housing. Or rates of physical inactivity. We're seeing planning really look at complete streets and safe routes to school, or the cumulative impacts of environmental pollution and environmental justice approaches. So planning is really touching back on the roots and taking that health equity approach once again. But I want to just call out the importance to be mindful that we need to do this work really through an equity lens. One of our colleagues in the healthy planning world is named Malo Hudson. He researches community health and environmental justice and teaches planning at University of California, Berkeley. And he's written a book on community engagement and equity in planning approaches. And I think that this quote is so important for us to be thinking about as Planners for Health. It's really our opportunity and our challenge to not contribute to reproducing inequalities and inequities. And in order to do that, we really do need to focus our efforts intentionally on directing our resources to where they are needed the most. So we wanted to highlight just a couple of ways that you can think about doing that in your work. We're not going to have a lot of time to get into examples right now, but certainly our speakers will share more about their work, and we can come back to it in discussion. We'd love to hear also what has worked well in your communities.
And one thing to really think about is that, everything that we've very quickly laid out, represents a vast set of work and a deep sense of work, really that's evolved over a lot of time and requires a lot of resources, time, and energy. So we're mindful that you're all in different places, and we're all in different places in terms of how best to take on an equity lens and advance health equity in the work that we're all already doing. Every day we make decisions in our organizations, institutions, agencies, and our communities that ultimately influence health equity in those populations and communities that we serve. So we recognize that some people are newer to equity-focused work and others are deeply immersed in it. So we encourage everyone to think about how your existing policies, practices, decision-making structures and mechanisms around funding and partnerships and community engagement can support health equity. So, there's a number of different ideas in the field and so many different resources. We're highlighting one here, which we, in support of the Centers for Disease prevention, helped to develop as part of a guide for advancing health equity called a Practitioner's Guide to Advancing Health Equity. And this, one of the major sections is around assessing capacity of your own agency, organization, institution to do health equity work. So I think it does a good job of laying out some important questions that can be done with your partners, with community members, within your management teams, et cetera, to really reflect and assess where you are, and then be able to determine what are some near-term opportunities where you can really apply a health equity lens, and where are there more aspirational opportunities to build towards norms change that really, counter production of inequities in the first place.
So we'll send out the link to this practitioner's guide, and I think the speakers will also share some other examples of what has worked well in their work. Two more quick examples before we do get to the other speakers. Another example of how you can think about building equity into your Planners for Health work and all of your work more broadly is through something called an equity impact review. Many of us are familiar now with a health impact assessment, or even, certainly for the planners, an environmental impact assessment, an environmental impact review. It's a required part of every planning process to look at what the impacts will be on the environment or on the health of the people who will be most impacted by the project. You look at the positive and the negative implications. So King County, Washington, which is where Seattle is, has taken this concept one step further and really intentionally focused on what the equity impacts of a proposed project, budget, policy, program, anything like that might be. So we can send out a link to this, and you can learn more by learning about what King County has done. But I thought it's an interesting thing to highlight, since so many of us are familiar with the environmental and health-focused impact assessments, to really take that deeper look at equity. And then one last example we wanted to shine a light on is what they've been working on in the Nashville area. The Nashville area MPO, for those who are not familiar, Metropolitan Planning Organization, which is how federal transportation dollars come down to different regions, and then how transportation projects get funded in regions. Nashville's MPO developed scoring criteria for their project review process. So localities from all across the Nashville region sent in proposals for the transportation projects that they would like to do. And the MPO then makes decisions about where those federal dollars are going to go. It has to be in alignment with the transportation plan that they've created. So they built in criteria into that transportation plan and into the project grant decision-making process, the scoring process, to prioritize health equity. So out of the 100 points that any project could get, up to 80 of those points were directly related to public health outcomes, safety, or equity. So as a result, the dollars that went out the door and went back to fund transportation projects in communities really did prioritize things like active transportation, safety, access to jobs and housing, schools and parks, and things like that. So again, we'll share this link. It's an interesting approach, we think, again, as Sandra said, to be building health equity as a consideration into all of our decisions, all of our investments, all of our projects, and into our own internal practices as Planners for Health. So we're really thrilled to be joined by two speakers that are going to share more about their work.
Sure. First, we're going to hear from Dr. Anita Arno, who is the director of the Washington District of Columbia Department of Health, Office of Health Equity. Dr. Arno is an experienced public health professional with a track record in the field of health equity. This includes national recognition for work promoting community collaboration to transform views and perspectives related to root causes of health disparities, the integration of health equity concepts into healthcare delivery systems, and racial equity through a public health lens. Prior to joining the team at DOH, Dr. Arno served as the Division Manager for Communicable Disease Prevention and Public Health Preparedness in the Kansas City, Missouri Department of Health. She has also served as a Director for the Center for Health Equity in the Louisville Metro Department of Public Health and Wellness, and as an adjunct faculty in the University of Louisville School of Public Health and Information Sciences. Dr. Arno holds a PhD in urban planning and an MPH in healthcare management. So we'll welcome her in just a moment.
And we're also joined by Martha Moore-Monroy, who's a lecturer and REACH program manager, in the Department of Health Promotion Sciences at University of Arizona's Mel and Enid Zuckerman College of Public Health. The primary focus of Ms. Monroy's professional career has been population health, which has included women's health, community health worker programs, and coalition development dedicated to the elimination of health inequities facing underserved populations. She's the Southwest Regional Director for the National REACH Coalition Board of Directors, co-chair of the CHW Workforce Development Committee for the Arizona CHW Coalition, a member of the Arizona Department of Health Services CHW Leadership Council, and has also been working on a Plan4Health project in Ajo, Arizona. So we're thrilled to be joining both of you, and we look forward to hearing about your work. Dr. Arno?
Okay, let me see if I know how to make this work from my end. Do I just click?
Yes, Dr. Arno, I'm just passing the controls to you.
Okay.
And Rachel and Sandra, are you able to pass the controls to Dr. Arno? My computer is being a little fishy.
We will attempt to do that right now, Eliza.
Thank you.
You can do that, but we can move the slides for you, Dr. Arno, until we get this figured out.
Okay. All right. Well, hello, everybody. I'm really delighted to be a part of this, and it really is very heartening to see urban planning and public health coming back together, and for us to collectively move the needle forward. Next slide. I thought I'd start with, I know most of you on the line are probably urban planners, but I thought I would share the mission of the District of Columbia Department of Health, and I've highlighted. We recently added the word equity. We've changed the lingo a little bit, but it actually says the District of Columbia Department of Health promotes health and wellness and equity across the district and protects the safety of residents, visitors, and those doing business in our nation's capital. That's important because we have really been we've been doing the work, but we've really embraced it for the whole department, even though we have just started the process of having an Office for Health Equity. The Office for Health Equity was only stood up in end of 2015 when I started here. So we were less than 2 years into my tenure here at the DC Department of Health Office for Health Equity. Next slide. So again, I think context counts. And so what I'm showing you here, the DC Department of Health, in some ways, and I think most of you, if you know anything about public health, all public health departments are very different one to the other. We are unique in the sense that we are a city, state, and county health department. So the District of Columbia just has one health department. We don't have a separate one as you would in different states. So we do multiple functions. So we're both a regulator of all the hospitals, healthcare providers, and all the other things in the city. But we also see ourselves as being an important role model and convener and collaborator. And so those two things, beyond what we are required to do or what we do by law or by statute, I think we leverage that a lot. Since I've been here, we've been talking about the 5 strategic priorities, which are to promote a culture of health and wellness, to address the social determinants of health, to strengthen public-private partnerships, to close the chasm between clinical medicine and public health, and to implement a data-driven, outcomes-oriented approach to program and policy development. You will note that the 5 strategic priorities don't have a specific number. I think in most instances, we apply those to almost everything that we do. And these are not just for me in the Office for Health Equity, but it really is infused across the whole of the department. Next slide. And I also thought it's important for us to think about health. Traditionally, both within public health and health care, and just it's pretty ubiquitous to people to think about health as being when you're feeling healthy. We really think about health, and this is critical to the understanding of health equity, that health is a state of complete physical, mental, and social well-being, and not merely the absence of disease and infirmity. So we're not only looking to think about health in terms of what hospitals provide, et cetera, but we are thinking about our entire life, and we take what we call a life course perspective from pre-birth to all the way through the life course. Next slide. Again, the social determinants of health, I think you will have seen one version of this, but this is the one that I like to use because it really demonstrates that 50% of our health, regardless of whether we have health care or not, or whatever we do, what we call health behaviors, 50% of our health has nothing to do with whether we smoke or drink or whatever in our genes. So a lot of it has to do with our physical environment and our social and economic factors. Next. I tend to go pretty fast.
I think you're moving faster than our computer is. Sorry about that. We're trying to keep up here.
And this particular pyramid, I like to share it because not only are we talking here about what drives health, how do we improve health? Typically, we think about if only people would do what their doctor says, or if only people would, go to the clinic and the doctor. The majority of what drives their health are the socioeconomic factors, the things that affect all of us. And so that second bucket, beyond the socioeconomic factors, that says changing the context to make the individual default decisions healthy, we are really saying that even our health behaviors are driven by the opportunities that we have. So if you don't have the opportunity to buy healthy food, you won't. That's not a choice. You're not. It's just not available. So some of the things that we think about in terms of socioeconomic factors are poverty, education, housing, and inequality, and smoke-free laws, etc. But for the most part, my work in the Office for Health Equity focuses on changing the context where people live, learn, work, and play. Next. And this really, I love this slide. I used to use the original, what we call the bar-high model, but it's really talking about, if you look at the bottom arrow, it's talking about, which I think was referenced by the overview, of the traditional medical model that typically people think about, or and the public health practice change, as opposed to how we can change things. What I especially like about this is that it focuses on policy, which shows up in the orange. That's really where we have the greatest opportunity to make the changes. So we need to change living conditions. We need to change our institutions in order to solve social inequalities. And so that's really a lot of what our work is. Next. And I know all of these slides are going to be shared, so that's why I may have included more than I potentially needed, but I think it's good for people to look back and review. And so just in terms of context, this gives you a quick sense. The District of Columbia is a relatively small area, population about 600 and nearly 90,000 people. But if you look at the life expectancy by ward and we look at the changes over time, we can see that by ward, i.e. by where people live, there are differences in terms of the number of years people can expect to live. And we can see for the most part, most wards have seen an increase in life expectancy between 2009 and 2013. However, that's not an automatic factor. So if you were to look, for example, at Ward 7, you can see that there was actually a reduction in life expectancy in that particular ward. So the gray bar is shorter than the red bar. So it's not an automatic thing that our life expectancy always goes up in the United States. And we've seen a lot of that happen, especially there's been a lot in the press about what has been happening to white working class folks in particular, but it's probably been it is something that has affected racial and ethnic minorities and people of low income for many, many years, although for the most part, it's hidden in terms of how we think about improving quality of life. Next. So this gives you a just very general, you can go back a little bit, but I think we skipped to next. All right, we'll go from here. The Office for Health Equity, therefore, was started off in 2015 with this mission. The Office for Health Equity works to address the root causes of health disparities beyond healthcare and health behavior. So all of the slides before were really to tell you that a lot of our health really happens long before we get to the doctor, long before we were sick, and in many respects, long before we were even born. So my Office for Health Equity, even though we're in the Department of Health, really looks to beyond healthcare and health behaviors by supporting projects, policies, and research that will enable every resident to achieve their optimal level of health. Next, I'm just going to go through it very quickly. The way we think about that is there are three key ideas here. Despite the many health resources, we've got a lot of hospitals in the District of Columbia. In fact, we have something like a 95% health insurance rate in the District of Columbia as well, and this is even before the Affordable Care Act. So what that demonstrates, as I showed you in the slide, health outcomes are not equal across the district as shown by the ward. So having health insurance in and of itself, it's a good thing to have. It's what I call a necessary but not sufficient. So in my book, health equity is everybody's work, and it requires us to really think about a health in all policies approach in which health equity is embraced across the district. So our overarching goal in the district, and that's the bottom bullet, is to improve health across all contexts, regardless of where people live, learn, work, play, and age. Next slide. So this gives you a little bit more about what I mean by a health in all policies approach. And it's really a data-driven and evidence-based approach in how we have even designed our Office for Health Equity. We're probably a little bit different than most offices, or what I would call a traditional office for minority health. So we really talk about leveraging evidence, data, policy, and practice. We apply a collaborative approach, and in fact, we recognize that health is created by factors beyond healthcare. And it integrates and articulates health considerations into all policy making. And it's really, we know that all the work is not done, so we still need to adopt a learning organization type of an approach. So we are continuously measuring what we've done and what our outcomes are likely to be. So it's effective in identifying gaps in the evidence and achieving health equity. So I'll also have a definition of policy. Frequently, when you talk about policy, people think, well, I'm not a government entity, I'm not a policy maker. So policy in this regard means a law, regulation, procedure, administrative action, incentive, or voluntary practice across governments as well as other institutions. And as you will see, we really approach it through a public, private, nonprofit. As I said, everybody's work is health equity. Next. Very broadly, this tells you about our strategy and our results framework. I operate in three major buckets, with the overarching goal being to improve the context for equitable opportunities for health. The three big buckets are building a multi-sector collaborations, and that's kind of an applied health in all policies approach, leveraging community-based participatory research, and demonstrating health equity practice. In many respects, many offices for health equity have tended to, and I'm not saying they all are, many of them, however, tend to be more about talking and training, whereas my experience has led me to the position where people need to see what you need. And we do that both internally and externally. A lot of what I will talk about today are more in the multi-sector collaborations, because that's really where we do a lot of our planning or working and collaborating with planners. So my next several slides will talk about what I do across government agencies, so that's the red bucket. How I work with community, including our plan to launch a commission on health equity, how I work with the hospital sector, and how we work with the private sector. Next. This kind of gives you a quick kind of fold out of those 4 things and some of the things that we've done. I know in one of the earlier presentations they talked about Vision Zero and how that work can happen, and that's really working with the transportation sector. I'm going to talk a little bit more deeply about our Buzzard Point CHASS, which stands for Community Health and Safety Study. We have visited with the Chamber of Commerce and are continuously working with grant makers, and then I also work on the community benefits with hospitals. Next. This is just to kind of demonstrate how we think about health equity in the District of Columbia and why it's important to even look at in terms of Vision Zero and how we integrate with the Vision Zero strategy. If we were to look at who are the folks who are dying on the streets of DC, we find that the majority of people who die on the streets of DC tend to be African Americans and people of color, and they also tend to be younger and older folks. So we integrate with the Vision Zero strategy through multiple strategies, and we really keep a lot of the data and present a lot of that. That's one of our core strengths at the Department of Health. Next. This gives you a little bit of an overview of the kinds of strategies that we are involved in. So, and I've put up there that it's a multi-sector partnership and it's DOT-led. So another thing about working on health equity, we engage whether we're leading, following, or supporting. I think that's the kind of an approach that is essential if you want to participate in moving the health equity needle. You don't only participate in the things that you lead. You have to support your partners. You have to engage with them in the strategy. And so another one of the strategies that we work on is working with vulnerable populations, and we've just recently, right at the bottom, I talk about the trauma repository that we've just set up here at the District of Columbia Department of Health. Next. Very quickly, this gives you a summary of how I work with our community collaborative partners in the hospital sector. And that's really leveraging the community benefits. I think there was also reference to that, so I do some of that work. The focus being to try to engage and inform the hospital sector to think about community benefit beyond giving out charity care or traditional health approaches, because they can be unique partners in helping us engage communities and doing some things in the community that support health equity. Next. And what I wanted to show here is that we have done the DC Healthy People 2020 framework. That is somewhat what we would call a chip in a way, but we have we developed it in collaboration with community partners, but it's also a shared community agenda. So we had planners involved, we had all kinds of different planners involved in the process, as well as hospital sectors. And so my colleagues at the hospital sector also developed their community strategy, and they're trying to work towards implementing some of those things. So we're looking at community partners across the board to help us with that. Next. And so now I'm going to get a little bit deeper into actual development and how that impacts and what the role of health equity could be. In December 2015, we were asked by community residents, as well as some of our community partners in the development industry, as well as the DC Department of Energy and Environment. There was a plan or a strategy which had been in play or had been being developed since 2014 to do a voluntary cleanup of a major site in the community and to redevelop it for a soccer stadium. And when we went on site, there was a lot of environmental conditions, and in fact, we were on the South Capitol Street Bridge, and we were literally standing in about an inch of dust. And that was really a demonstration for me that what the folks who live in the vicinity of Buzzard Point were experiencing on a daily basis. Next slide. So we ended up working with our partners across the district, and we did what we call, during the phase 1 strategy, a community health and safety study. When I first arrived at the district, there was some draft legislation about doing health impact assessments. And that did not get a second reading, but I still thought it was an opportunity for me to learn and to work with communities. So we set up a guide as to what we would do. And I think the largest part that was important was that we not only looked at what was going to happen at the soccer stadium, but we undertook the community health and safety study to address the potential community health and safety issues for the public in the vicinity of this voluntary, multi-phase voluntary cleanup and redevelopment in Buzzard Point over multiple years. And I think that was important. Our study task list was pretty extensive, and we started doing that work in collaboration with the community as well as our district resident partners and the developers. Next. One of the challenges of doing this work was collecting what data should we collect. The Department of Health data in terms of health metrics are typically collected at the zip code level, but the part of the district that was really experiencing the brunt of the development was in census tract, the one on the bottom right, which is census tract CT064. And really looking at the district at a lower, more granular level was critical to our understanding of what was going on in the district or in that vicinity. The average income across the whole of those, if we were to do it for the whole of the zip codes, was $100,000. However, if we looked at it in terms of the census tract 64, it was $34,000. So that really tells you that sometimes averages hide a lot of inequities. Next. And I probably need to hurry up a little bit. This gives you some data from the census tract level, and when you look at those data points, you really see that in terms of health outcomes data, and you compare the Buzzard Point area to the rest of the district, even though there were slight differences in rates, they were not considered to be statistically significant. Next. However, if we were to look at from a census tract level in terms of the American Community Survey's data, we could see significant differences in terms of different metrics that would be the outcomes in terms of social and quality of life and socioeconomic outcomes. Next. And so that's just the other four. Next. So ultimately, what this says to us is that in traditional times, we would, from a public health perspective, we would have looked at the data and walked away and said there is no health impact, narrowly defined in terms of statistical significance. However, knowing that the folks who lived in the zip code 064 had less what we would call protective factors to be able to defend themselves against the onslaught of the development as well as the dust that was coming, just as an example, we provided some recommendations as to how to improve the process, and that included these 5 major recommendations. But one of the things that was the outcome of that was that the developers, DC United, provided, I think, and in collaboration with other developers, provided about $100,000 for community residents to buy filters to put on their homes. So that was a major outcome just for me. So that was one of the things. Next. And I'll really speed it up now. Currently, we're working on the comp plan. We are a major collaborator with the District of Columbia Office of Planning. They're starting a new comp plan element. I know the best practice across the country is to have a health element. When I arrived here, they were primarily talking about, they had already talked about a resilience element, and they were primarily thinking about it in terms of emergency preparedness and climate change. However, with my participation, and I think there was a genuine willingness to do that, they started thinking about a resilience in a much broader frame of reference, and so they started thinking about the framework in terms of the built environment, health and well-being, economics and society, leadership and strategy. Next. And these were kind of the guiding principles as they've gone about developing the resilience elements and new elements in the comp plan. And I've highlighted a few things like addressing diversity of stresses and shocks, addressing and promoting equity, addressing social and economic infrastructure, and expanding partnerships to address the complexity of problems. So really, they have really embraced the health in all policies approach to developing the resilience elements in the comp plan. Next. And these are really thinking about the comp plan. These are the things when the idea here is that if we do not address the chronic stresses that people live with on a daily basis, they will not be able to be ready to respond if we have acute shocks. And I frequently reference what happened at Katrina, that even though they had a plan, the fact that some folks did not have their own private transportation was a little bit of lack of insight into the chronic stressors that people live with. And as you can see here, the definition of chronic stressors include crime and violence, homelessness, and lack of affordable housing, some of which look like they're natural fits in a built environment planning perspective, but others not so much. Next. And so these are just very quickly some of the draft resilience elements, draft policies that have been developed. There were a total in the first draft that came out in February 2017. I think there were a total of 160. So you can see that it covers housing, infrastructure, transportation, natural resources, etc. And then in the health and well-being, they talk about inequities, health, and human resources. Next. And similarly, we have more, as I said, out of those total, we have draft policies that are being developed under these other umbrellas, including economy and society, and the changing economies, and the need to revitalize and strengthen neighborhoods. But they also address this notion on the right-hand side, leadership and strategy in terms of government engagement and public-private partnerships. So I really think that our engagement in the process has been very helpful. The next slide shows some of that engagement from a governance perspective. So DC at the end of, or at the beginning of, May 2016 got inducted into the 100 Resilient Cities with the Rockefeller Foundation, and that's really provided us with an excellent opportunity to engage a broad swath of policy folks at the district level into a health and all policies and equity agenda. Next. And this kind of just why I've provided this slide is to really show you the breadth of involvement of the caliber of folks who are involved in the leadership, direct participation by the Director of Health, the Director of Planning, and the Director of Energy and Environment, who that triplet have been largely some of the drivers of the process. But we've got the city administrator engaged in the process along with the deputy mayors and some other folks. So really what we've done there is replicated what we call the National Prevention Strategy that was launched under the Obama administration, but we're really doing the same kind of thing beyond the what was traditionally the health cluster in the District of Columbia. Next. And I think my next several slides really talk about the importance of data and going deeper. So just let's go to the next slide. And next. This really talks about the need for us to be more granular in our approach in terms of what we're doing in terms of developing an upcoming health equity report that looks beyond and at the lower level than the awards that I showed you the life expectancy earlier. And what we're doing is overlaying life expectancy with multiple data sets in terms of trying to have this conversation across the district outside of the traditional health sector and engaging all of those partners that you saw in the resiliency strategy. Next. And so that was education, and this is about income and employment and the notion that a job, you need to have quality jobs, so we were engaged in that discussion. Next. And I think that's it. So.
Thank you so much, Dr. Arno. We will now pass things over to Martha Moore-Monroy. And Martha, I'm click through your slides for you as well. So just let me know when you want me to move to the next slide. Thanks.
Hi, sure. Hi, and I'm sorry, I may have to cut this a little short because I have to leave to teach in about 5 minutes. But really to build on some of the things that the previous folks have been discussing, talking about what that looks like in a small frontier community. I know there's been a lot of discussion lately nationally that look at rural populations as being primarily white, and that's really not the case. Ajo, Arizona is a small frontier community of about 3,000 people close to the U.S.-Mexico border. It's predominantly Latino, and if you could switch, I can talk a little bit more about that. So what really this focuses on is community health workers as when you're looking at health equity work. Community health workers are that bridge between the community and the local agencies, including planners in public health. And so what I'm hoping to talk about really quickly is what is community health worker-led policy systems and environmental change. What is it? How can it impact the long-term health of a community? How can it sustain positive change and provide resources? How can this model sustain change, and what roles do CHWs play? Okay, next one. So this builds on 12 years of experience in community-led approaches rooted in the Sunnyside and Elvira Advocates for Health. And the Sunnyside and Elvira Advocates for Health were a local community-based coalition within Tucson, Arizona. We're a city of about 1 million people. And what we did is we adapted that model to build on the assets and address the special challenges of and distance of an isolation from resources for a frontier community. So this community, Ajo, is an hour and a half away from the nearest hospital, and it is an aging community. And once the mine pulled out, they pulled all their resources out with them, which is about 30 years ago, and they're still recovering from that. Next slide. Okay. So Pima County has had a very robust bicycle education program and bicycle promotion program for transportation. And again, both Pima County and particularly the Latino population and within Tucson and in Ajo have high rates of chronic disease, including diabetes and CVD, chronic cardiovascular disease. And so having access to cycling for health, transportation, economic development, and recreation has been really important for both communities. Next slide. So prior attempts and this is, we developed a bicycle center within one of the Boys and Girls Clubs within the South Side, which is about 86% Latino. About 80 to 89% of the kids are on free or reduced lunch. And so we developed a comprehensive cycling center. There's very high rates of type 2 among the children in that district. So we developed a comprehensive bikes program within the Boys and Girls Club there. Next slide. This is to give you an example of how rural it is. Those are the bikes that we purchased for the community making their way to Ajo, because between Tucson, which is the center of our county, and Ajo, Arizona, is the Tana Atam Reservation. It's about the size of the state of Connecticut. So between Ajo and the county seat is a 2.5-hour drive. Next, please. So this is the middle school program. These are the children that they came when we delivered the bikes for the bike program. Next slide. So this will give you an example. If you can see that map, if you look up all the way to the left where it says Organ Pipe, you can see Ajo, and you look all the way to the right, and that's Tucson. So that gives you an example. The Tohono O'odham Nation is the size of the state of Connecticut. So imagine in your states having a state in the middle of your county that separates your community from the major metropolitan area. Next, please. And so one of the things that we talk about is expanding and sustaining effective partnerships in the community to create that roadmap, and that's what we refer to as the roadmap to create the design for that project. And these are some of the community members. On the left is two folks from the Pima County Department of Education. We had the Community Health Center involved, and there's the principal and the superintendent from the school district and the children that were involved in it as well. Next. So the first thing that we started with was a community assessment, and one of the things that we tried to pull into AHO in addition to cycling resources, because we know that the bicycling and not having access to physical activity and having high rates of diabetes is just one symptom of a larger issue of lack of access to resources. So on the left, you'll see some of our graduate students who went down to the community to help provide the manpower, and this is one thing that we always stress, and universities are great resources. One of the things that we always stress with our public health students is that you are here to serve the community. They are the community experts, and so we have them come in, and we have a great program or emphasis on community service at the University of Arizona. So they came out, we conducted a bikeability assessment in one day, and this is so interesting about working in small communities. They went to do a community survey about, the assets and barriers related to cycling for health, recreation, and economic development. And I thought, in a day, maybe they'll get 50 surveys. They got over 100 surveys that first day, just from the parents picking up their kids from school. And there are only 3,000 people in the entire community. Next slide, please. And so that was what I was talking about. We did joint community and bikeability assessments. The resources that we were able to leverage from the Plan for Health enabled us to allow the Pima County Department of Transportation, because you can imagine what the cost is to transfer bicycle staff and training folks in a 2.5-hour drive and distance. So what we were able to do with these resources is to build the capacity within the community that not only helps that systems change to provide bicycling as a resource, but also we were able to create a health careers club that will improve access to higher education for a lot of the children there that they didn't have before. So what we were focusing on cycling and diabetes prevention, but there were so many other pieces and multiplier effects that occurred from the capacity building within this particular project. Next, please. Okay. And so one of the things that people get a little afraid of, especially on the community level, is when you talk about policy systems and environmental change, they usually think the big P. So we always talk about the big P and the small P, and I do this with our students also, is that, those, real systems change and real impact on inequities takes a long period of time. And so you have to start at the, small steps, especially with communities. And so this is one of the things that we talked about in terms of what are those small changes if people feel comfortable. And as they feel comfortable, then that can blossom into others. Next, please. There's some more pictures. So some of the capacity building that we did was connecting the folks from Desert Sunita and community members with our statewide community health worker organization, so that then they can have that continual tie to do constant capacity building and really expand their ability to serve the community. And we also did digital storytelling training that will help the community advocate with local, state, and federal government agencies, as well as to disseminate information. And our digital stories are on the Plan for Health website. And so when you look at those stories, you can see that they serve multiple purposes. And digital storytelling is something that community members, it enables community members to tell their own story. So when community members can't make it to the Board of Supervisors meetings or make it to the state capitol, we can take those stories with us, or we can email those stories to the policymakers and enable people's voices to get to those larger policymakers. Next, please. So collaboration is really important, and these are some of the ways that we collaborated with planners on this particular project. I have about 12 years of experience working with planners in our county on public health projects at the community level, and it's been really successful. And so these are some of the ways that we're able to collaborate. Next, please. And so ongoing community engagement is key to the success and the sustainability of these types of events. And so you can see in the smaller level, that's one of our league certified cycling instructors leading some Cub Scouts on a ride through the desert. On the bottom left, again, safety factors when we did the community assessment was the #1, and that is always consistent. So teaching people how to ride safely in traffic. And people don't realize that actually it's more dangerous to ride a bike in rural areas than urban areas. You know, people used to think urban areas because there's more traffic. In rural areas, the infrastructure is not as good, and particularly in Ajo, it's not very good. And secondly, people tend to drive very quickly, and especially through Ajo, because people drive through Ajo from Phoenix to get to Mexico, because there's a beach about an hour away from Ajo in Mexico, and so you get people that will often speed through the community, so it can be quite dangerous at times. So these are some of the ways that we were addressing the concerns of the people in the community. Next slide, please. And so I'm a big, and again, I have to leave soon, but I love to show pictures of the actual impact. So we can talk about statistics, and sometimes when you're dealing with policymakers, you need to put a face on the stats, because sometimes, and the statistics are very important. And what we do is we combine pictures and stories with the hard statistics so people can connect the impact to the statistic. And we found that this has been very effective. Next slide, please. So part of what the community will, the big issue when you're working with underserved communities is, and it's a genuine concern, is that, oh, you're coming from the university and, you're just gonna, once the grant's over, you're just gonna leave. Or a big case is that the community itself will get a grant and it'll get pulled by the funder, which is what happened to the REACH grantees, which is a CDC project. About 5 years ago, the prevention funds were pulled, and the local communities lost their grants. And so one of the things that we've always found is key when partnering with the community is to start planning as if the money's going to go away tomorrow, which it often does. And so one of the big keys to doing that, or one of the most important things to doing that, is to build on those assets that exist and really talk about pooled resources and think about things that can be done without funding and can be sustained without external funding, where people can just pool those resources. And so here's some of the things that have come across for us is we expanded the programs in the clinics for worksite and patient wellness. So the cycling program is integrated, and so that's an example of a policy and a systems change at a micro level. That one of the things that they're talking about is a sliding fee for technical assistance to replicate and provide revenue for the cycling club. So we bought 50 bicycles for the community, because there's no place to buy any kinds of tools or supplies for bicycles in the community. And so what we're doing is creating a sliding fee, because a lot of snowbirds go down there, for people that come down and spend the winter down because it's nice and warm in Ajo. And we're also developing an agreement with one of the bike centers in Tucson, so that they can sell bike parts on a commission basis, so that not only do we have the bikes in the community, but people who do have bikes have access to those bikes to fix them. And then also, because once the mine left, most of the jobs went with the mine. And so to create another economic driver within the community is one of the, and to sort of tie into those folks that are going to Mexico and those folks that are going into Oregon Pipe to build on those assets is to develop a sense of bike tourism so that folks can, so it's also an economic driver in creating jobs. And then again, like I said, the supplies on concession. Next slide, and then I'm going to have to run because my students are waiting for me. I apologize. So again, you know, once the Plan for Health program ends, the middle school program, so we integrated the bikes both into the bike system, both into the school district and into the community health center. The community health center will take over the adult bike program in conjunction with their conference center and their tourism center, and then the school and Pima County Department of Transportation will take over the youth bikes and then also continue to teach the classes there. And prior to that, the community had no access to the bike program at all. And I'm going to have to apologize. I'm going to need to leave right now. If you have any questions, you can certainly send me an email, and or send an email to the planning folks and American Planning Association folks, and I'll get back to you on that.
Thank you so much, Martha. So that brings us to our discussion portion of today's webinar, and I will pass things to Rachel and Sandra to kind of summarize some of what we just heard before kind of diving into some of your questions that have been coming in via the question box, and keep sending them in, and we can get to them all hopefully.
Thank you, Eliza, and thank you, to our speakers today. I think there's such a level of richness to the stories and to the experiences they shared, and we want to come back to some Q&A. We know folks have been sending some questions and some requests, so we'll address those. But just wanting to, one, the importance of really showcasing efforts at an urban setting and also a rural setting, and acknowledging that, this health equity lens can look differently depending on the community and the outcomes and the priorities within that community. So, one lesson that I think public health has learned and continues to learn from is that, we can oftentimes think about using an equity lens to an issue, issues of chronic disease or lack of access to certain elements that support individuals' behavior to be healthy, but we don't oftentimes apply that lens fully to those strategies that really get to broader systems and norms change. And so, that lens to health equity solutions ability is really important. And whether it's our DC example that really is building on a lot of their efforts through this Office of Health Equity, or Dr. Monroy's example in a rural setting, I think that comes up a lot. So it looks differently, it takes place differently, and that's okay. A lot of what is coming out from each of those examples is a real sort of examination of the capacity, opportunities, and partnerships for each group to advance health equity, not alone and not in a silo, but really working with community leaders and with health systems and with partners in different sectors.
I think, excuse me, public health is so strong in terms of data collection, and we've now talked in the last couple of sessions about the importance of collecting data and looking at differences in outcomes, and so highlighting inequities, using the power of maps and things like that to tell the story of where public health challenges are greatest. So I think that we have come a long way as planners and as public health practitioners in highlighting the problems with health equity. And now I think our challenge is really to come up with the solutions and to highlight the ones that work. And I think that's why Planners for Health is such a great opportunity to be sharing questions, to be sharing approaches, to be sharing ideas across the whole nation. And as Sandra said, urban and rural and suburban contexts. So I think very curious and eager to invite everyone to be chatting ideas and chatting questions that are coming up for you as you hear this. I think Eliza will get to reading a couple of questions in just a moment, but I did want to highlight two that I saw coming in that I would love to pose to Dr. Arno just to get us going. One is on the question of how do we know if we're being effective in reducing health inequities? What are you measuring? What data are you collecting? And how do you know that you have been effective? So I wonder, Dr. Arno, if you could share a little bit about your work in that respect.
Right. So I think I included in my slide deck what we call it the results framework. And that was the one where I showed you the different things that we're working on. So each of those elements, we typically have a measure as to what our objectives are. Some of them are quantitative measures, and some of them are qualitative measures. And so I think it varies. Because the work of health equity, one has to really think of the long view and not necessarily the short-term view. And people should not be expecting to see an immediate outcome. So we're not expecting health inequities to change overnight. And so some of them will likely be process measures. So did you do something differently? I think one of the examples that I included where I talked about the fact that in past times when neighbors or community residents complained that and I think that's what happened in Buzzard Point, the sense was that they had higher rates of disease, higher rates of cancer, and all kinds of things. Somebody would come to the Department of Health, and we would go around and we would measure it, and we would say, yes, there's a slight difference in number, but it's not statistically significant, and therefore there's nothing we can do about it. I think what we embraced in this process was digging a little bit deeper, which is what I was trying to demonstrate in those few slides that I showed, that if we continuously look at too high an average. So again, what I also showed was traditionally in the district we've looked at the ward level, and we could see difference in outcomes. But what we really have are pockets of smaller areas that are, their challenges are lost at the higher average level. So I think some of the work has to be qualitative in nature. I would say that while I can't say that the folks in the Buzzard Point area are going to be, in a traditional measure, healthier because of the work that we did, the very fact that because of the work that we did, we caused the DC United folks, as well as some other community partners, to contribute, which they're not required to do. There was no legislation making them do that. Decide to put $100,000 into the community to support residents in their efforts to buy filters to put on their homes, whereas the other folks that I showed you in the other parts of that zip code could probably go out and buy one, even though they all lived in the same proximity, even though in theory they were all exposed to the same level of dust and the other things that were happening. There was a qualitative difference in terms of ability to respond, in terms of their health protective factors, if we see that through the lens of ability to purchase filters. So there are multiple ways. I think each project is unique. Some things are purely data-driven and others are just qualitative.
Thank you, Dr. Arno. I wanted to mention one more thing before Eliza starts reading some of the questions that are coming in, and that is we had a comment come in response to what Dr. Arno was speaking about before, and I know also at Prevention Institute we're seeing this issue come up a lot, about some of the unintended consequences of healthy planning work. And I think particularly in urban areas and in regions surrounding urban areas, the connections between health promoting infrastructure, so things like parks and bike lanes, complete streets, transit and transit-oriented development, and gentrification and displacement. And so at the beginning, when we talked about how planning has this opportunity to continue the public health approach and the real need to have this be equity driven, I would like to raise this tension, which I'm sure many people are coming up against in their own work, that if we don't build in proactive protections, so policies and affordable housing approaches and things like that from the outset, that our healthy planning work may have the unintended consequence of contributing excuse me, to rising property values, and then low-income families and historically many people of color are then pushed out, small businesses and residents, and have less access to the health promoting resources that we know will support community health. So I would love, in terms of comments in the chat box right now, and also follow up from this conversation. It's an issue we're thinking a lot about at Prevention Institute, and working on some strategies that people can think about. But I really do think it's an important thing for us to think about the equity impacts of all of the decisions we make in that way, and again, to be sharing solutions across the field. So with that, we'll turn it over to Eliza to start bringing in some of the questions that y'all have asked. And I know one question was on sharing the King County Equity Impact Review link, which we'll be sure to do in follow-up. We will share links to all the resources we've mentioned.
Thank you, Rachel. Yes, we will share resources, and the recording for this webinar will also be available within the next week or so for additional links and notes about resources that were discussed here today. So just a quick question for Dr. Arno about the size of the Office of Health Equity in DC. How many full-time staff members do you work with?
Okay, so we are surprisingly small. Apart from myself, I have 5 team members, and then I also had a couple of grad students that have supported some of our work. But I like to say that we are small and nimble. As I mentioned before, I think at the beginning of my presentation, the traditional, what I would call traditional disparities work is still done by the other administrations at the Department of Health. So data-wise, there is a Center for Policy Planning and Evaluation, and they keep all of the data, all of the health statistics, et cetera, for the District of Columbia, and we have access to that. I have partners in what we call the Community Health Administration, and they do, I wouldn't say it's traditional, but they do some of that health, what we would call traditional health work. But they are also changing. So when I showed, which is why I framed it the way I did, of us being a regulator, role model, and convener, we're also moving to a different kind of vision for what the role of a public health department ought to be. So that includes that we see ourselves not what a traditional health department did, which was in many respects being the health care provider of last resort. We are not behind a lot of providing shops, et cetera, for kids or adults or any of that. So we are really supporting moving our community partners, who we increasingly work by and through and in collaboration with. So that Health in All Policies approach infiltrates everything across the health department. So we have a lot of community partners through whom we work, and we really are focused on the strategic policy development and policy change. So that's a long answer. So yes, the core of the Office for Health Equity is small, but I really see the rest of the health department as being my core partners when I'm looking for subject matter expertise.
Great, thank you. Another question that has come in is asking about if there are standard health resources where planners can see data about the greatest chronic disease issues facing their communities. Thinking about it in terms of whether it's uniformly shared in one place. So I'll turn that over to PI and Dr. Arno.
Thanks, Eliza. Public health does a good job of developing resources and collecting data. So I imagine that maybe part of that question comes from more localized or regional data. We feel we work a lot with public health departments, and you know, they take a lot of pride and ownership around gathering data and information. Many counties make that data available via portals on their own website. So I encourage folks to kind of take a look at some of their local or regional agencies. And then we've also seen a lot of philanthropic organizations, academic researchers really create platforms from that as well. We know Robert Wood Johnson Foundation and their county health rankings work has really helped to transform a lot of the ways in which people kind of present issues in the community, and then also help to influence the strategies to address them.
And I think, like we talked about in the last session on data, I know some people may not have been on that session, but we talked about the importance of qualitative data as well. And Dr. Arnaud brought this up, that lived experiences of people who live in communities is a really important complement to any qualitative data that you may collect. And we see this come up a lot where data are not available on a very local neighborhood level. And so if all you have is a county average for type 2 diabetes rates, for example, that's not really going to help you understand where planning interventions are most needed on the neighborhood level. So we always encourage people to get out and do neighborhood walkability assessments and surveys and community-based participatory research, and engage with organizations that are really anchored in the community that may have a lot of that more experiential information already at hand and can help connect you with communities that are experiencing health inequities to share more about what they need and what they envision.
And I would, this is Anita, I would also suggest for folks who are saying where do they find data, I think they should collaborate, go directly and sit down with your folks at the health department. Frequently they have more than they would necessarily just publish online, or they would have the in-house expertise where they could help you. If you may not find what you think you want, because sometimes you say this is what you want, they may have a good surrogate data set that could help you with that. But I think actually if you want something, going and speaking to folks at the health department and asking them and collaborating with them, to me that's an important step. Because to me that's really where not just the data, I think the collaborative relationships and them knowing, even if they don't have the data today, you're asking for a particular thing may cause them to rethink how they analyze their data, deliver their data, etc. So I think they would be, I think most public health departments would be happy to partner with you. If data is your concern or you can't find it readily, I think you should approach the public health department, and they're likely to be a good friend. And if the first time they're not that helpful, try another time. I'm always in the vein of ask anybody for anything that you want. And the other thing that I mentioned, I think I talked about leading in the partnership approach. You have to be a little bit opportunistic. You have to lead, follow, or support as needed. So try to do a lot of that, because that's the way to influence people in what they are thinking about and what they want to do.
Great, thank you. Another question we have is thinking about recommendations about overall health equity metrics or proxies that can be tracked at the census tract level. And this comes from Seattle, where there's an effort to support environmental justice and equitable development to neighborhoods in industrial areas, and they're trying to establish racial equity outcomes and looking for corresponding indicators around that. Recommendations on that?
Well, I think I mean, I think you just have to pick something that you think is what works for you. I showed you a little taster at the end of my slide deck of the health equity report that we're trying to put together. Currently, that's what I would call our baseline assessment that will look at a lot of what I call the social determinants of health. Our next phase is to cross-multiply some of that data so that we have a health opportunities index. And I think one of the earlier presentations talked about the health disadvantage index somewhere in California. So that's a similar kind of criterion. But some of measures of segregation are also important because that's a really important part of an underlying root cause of a lot of these disparities. So when we looked at, and this is doing statistical analysis, using where people live in the District of Columbia, using race, ethnicity, income, and wealth, we were able to demonstrate that 70% of the differential health outcomes have to do with race. And then, that could help inform your process. I think there are a lot of efforts that really talk about segregation. And so frequently, that's why telling those kinds of stories are important. Frequently, people say, well, we've had the civil rights era, it's over, it's done with, but it persists in the arrangements that we have in how our communities are designed and how our communities persist, including segregated housing, which informs frequently when people start talking about neighborhood schools, and all of those kinds of calculus are really built on top of some social and structural and physical arrangements that are really rooted in a prior era. So, I think all of those things come together, and that's why the conversation about the data and even our health equity report you need to have conversations, not only, and I want to underscore that, frequently people want to have conversations only with the impacted communities. I think it is critical that we have conversations about these issues in all parts of our community, because that first slide that where we were showing the difference between equality and equity, if our goal is to change the outcomes, then it's not so much that we are taking away from some folks who feel that they are not getting their quote-unquote equal share of the pie, but so much as ensuring that the outcome is appropriate and that some people may need to step back a little bit and not demand their theoretical equal share, as opposed to ensuring that other people have an equitable share. So that would be my 2 cents. When we finish our health equity report, our full commitment is to have conversations all across the District of Columbia and across all of those wards, regardless of whether they think that their health outcomes and their overall life expectancy is increased, because our data is showing that we still have pockets regardless of the ward.
I would just add, Dr. Ono, we agree completely. We're nodding vigorously over here at Prevention Institute, and just wanted to add to the question about metrics to underscore the importance of not just looking at place-based metrics, so not
Correct.
just looking at the changes in what the transportation infrastructure looks like, or how many parks there are, things like that, how many developments were built, but also looking at who has been able to benefit from those investments. So looking at neighborhood change in population over time also is really important.
Right, and that was an important part of even the conversation that we had in Buzzard Point. A lot of folks said that was the first time that the health department engaged in that kind of way. And it really demonstrated for folks that the averages, as I said, average of 100,000, but really some folks were living at a 35,000 level and others were at 150, 175 level. And so we're not equitable in terms of the impacts. Even though those communities all supported the effort, they have to live through the actual development phase. and some of them may not survive it. So the inclusion, so our participation in the comp plan and our strong support of applying an equity lens in the comp plan and expanding the definition of resilience to include thinking about the chronic stressors that people have to live with are critical as we go forward.
Well, this brings us to our time. I just want to thank everyone so much for joining us today, and a special thanks to Dr. Arnaud and to Rachel and Sandra from the Prevention Institute for answering all these questions and sharing this important information with us. Thanks, everyone. Have a nice day.
Thank you all.
Thank you.